Dr. Lee, there's a question here for you. I have chronic pain and swelling in my right knee. My doctor wants to do surgery. Should I try the injections first? If so, how do they work?
Okay, thank you for that question. So when somebody has swelling in their knee, we tend to call it an effusion. That's the doctor's term, but in layman's term, we say that's water on the knee. So normally our knees have what we call synovial fluid. It's the lubricant that exists within the joint. It's almost like oil for an engine. And when the knee is irritated, injured, or some type of process is going on, the body will make extra fluid. And when that extra fluid gets to be too much, you get a very swollen and painful knee. And when you come to the orthopedic doctor or the rheumatologist, our job is to figure out why that happens. And so there's there's a long list of causes, including arthritis. It can be from an injury. It can be an autoimmune disorder, a number of things. Once you have that diagnosis, was it a mechanical injury? Was it something else? Then you can decide whether injections, physical therapy, medication, or surgery is indicated. So in my hands, I want to figure out why the swelling is there. And if I feel that draining that fluid out and injecting medication into that knee is helpful, that's something that I'll discuss with the patient. How does the injection work? Well, there's a list of types of injections. I'll go over two of the most common. One is a steroid injection, and it's meant to cause a decrease in inflammation and pain. Oftentimes, we'll combine that steroid with a Novocaine-like medicine like your dentist would give you if you numb your tooth. We call it lidocaine or Marcaine, and we'll mix that with the steroid with the hopes that we'll shrink down that fluid and cause of pain. Oftentimes, that is a temporary way to treat the knee before any type of surgery. The other type of injection that's commonly used is I call it chicken grease, but it's hyaluronic acid. It comes from a rooster's comb, and it actually is a lubricant that's meant to inject in the knee when people have too little fluid. In your case, I would certainly find out why the physician is recommending a surgery, and really make a shared decision between you and that physician to say, is this the right move? Injections, I think, are a very useful tool. And as long as you know the reason why that swelling is there, that is a good option.
All right, thank you very much. Yeah. Dr. Court, there's a question here about high blood pressure. Can you talk about the effects of common antihypertensive or high blood pressure medications? Is there any way to mitigate them or not be affected by them as far as the side effects are concerned? I think they're talking about. Can you speak on that, please?
Normal blood pressure is usually 120/70. Once that 120/80, once that number goes above those two numbers, you're diagnosed with high blood pressure. There are several forms of treatment for high blood pressure. One of the most common forms of treatment is called diuretics, or commonly called water pills. What these water pills do is they bring down the blood pressure by causing the body to excrete salt, and it has many side effects. Some of the side effects would be a low potassium, a low serum sodium, a low uric acid. It can also cause your blood sugar to go up. Also, your lipids or your fats in your body can also go up. It can also affect your magnesium level. So you see, this is multifactorial. There are several things that we have to consider in order to counteract these side effects of the medications. One, you have to, if your potassium is low, of course you have to reduce potassium. And the same would apply to if your blood sugar is high, you give the patient medication to bring the blood sugar down.
All right. Are you finished, Dr. Court?
For now, there are other medications that you use to treat high blood pressure. Mm-hmm. The second category is those are called ACE inhibitors, or ARBs. These are relatively new compared to when I went to med school, but they do the same thing, and they're very good in terms of patients who have high blood pressure where there's some protein in their urine. because with high blood pressure and proteinuria, you're at risk for kidney failure. And one of the good effects of these medications, they can prevent that.
Right. Go ahead, Dr. Court. I keep interrupting you. I'm sorry.
Another type of medication that we use, these are called beta blockers. What these beta blockers do is they slow down the heart rate, but they also have side effects. They can also make your blood sugar go low, and they can also, as a result of your pulse rate being low, you can pass out. So those are the major things that we use to treat the high blood pressure. There are other treatments, of course, diet and exercise, and that's just about it. Those are the major.
All right. Thank you, Dr. Clark. Dr. Court. Dr. Sprott, is there anything you would like to add to this? Take yourself off of mute, Dr. Sprott.
You know, my approach to most of the things that can go wrong with the body start out with what's the normal process that takes place. You know, blood pressure is regulated to keep it within those normal values that we talk about. And so when you think about the things that are components of a normal blood pressure, it's really three things. It's the amount of blood volume, which is the blood that's within the blood vessels. It's the size of the blood vessels, or the vascular tone. You know, the blood vessels are sort of dynamic. They can dilate or they can constrict. And if you think about, you know, a tube that has a certain volume in it, if it constricts, it gets tighter, the pressure goes up. If it dilates, then the volume in there is in a wider diameter, the blood pressure goes down. So the blood volume is one of the components. And then the blood vascular tone is the other. And then the third is how forceful the heart contracts. And the heart contracts forcefully, you know, if you exercise or other things. But it's those three components that are responsible for a normal blood pressure. So if your blood pressure goes up, it's because your heart is pumping more forcefully, the blood vessels are constricted, or you have an increase in your blood volume. And there's certain hormones that regulate, you know, what your blood volume happens to be. So if you're going to treat high blood pressure, you're going to be treating one or more of those components. When Dr. Clark talked about a beta blocker, he's talking about a drug that makes the heart not contract so forcefully. When you're talking about the size of the blood vessels, in order to make the blood pressure go down, there are drugs that cause the blood vessels to dilate. They're called vasodilators. And he talked about ACE inhibitors. There are others that do that. And then the blood volume, he talked about a diuretic. And what the diuretic does is it gets rid of usually sodium, which is salt, and along with that salt is water. But understand that with any of these treatments, they don't really affect the reason that the blood pressure is high in the first place. So whenever you take these measures, for however long those medications work, when they wear off, the things that are regulating the blood pressure are going to try to regulate it back up to what's high. So let's take a diuretic, for example. You take the diuretic and you pee, and you lose blood volume and your blood pressure goes down. Now, the hormones that regulate the salt say your blood volume is down. Retain salt to retain the water, and it goes back up again. So in order to keep your blood pressure under control, you need to be taking these medications constantly. And they all have side effects as he spoke about. The same thing happens if your blood pressure drops, okay? If your blood pressure drops either because the heart isn't contracting so forcefully, you're dehydrated, or you've lost a blood volume, or your blood vessels have dilated, okay? You've heard about the people that faint. A lot of people that faint because they are vasodilated, they might be dehydrated, they lose blood volume, and if they don't get enough oxygen, which is part of what the blood pressure does, pump blood to the brain, you may faint. Right. And so there are lots of complications with these drugs, so that, you know, you talk about trying to decrease the blood pressure, but if you decrease the blood pressure too much, you become hypotensive, and then you need the opposite. You need to increase volume, constrict the blood vessels, or make the heart contract faster. Sure. And so you need to start to consider these issues of what's normal and what regulates normal. And then what goes wrong, and we don't know. we've talked about pain a couple of times. One, chest pain. You know, there are only a few things that are responsible for pain, and you need to consider whether or not it's pain due to injury or pain due to inflammation.
Okay, we're gonna have to sum this up. Just give me 30 seconds and sum it up.
Yeah, what I was gonna say is that you need to think about, always think about what may be responsible for whatever the symptom is, and then try and figure out which of the reasons it is, and then what kind of treatment you might need for that.
Okay, thank you, Doc. Thank you, very well said. We're gonna go to one of the questions that just came in. And this is a question and something that's happening to all of us right now. We're all dealing with it. I test positive 2 times, okay? 2 times for COVID. And I am asymptomatic, it states. I am required to take another test. I need to know what's the next step. All righty, let me click this out here. So we're talking about somebody that's had 2 tests for COVID. Both of the tests were positive. They're going to take a 3rd test, from what I understand, and they're still asymptomatic. Can anybody chime in on this? Give us some indication of what's going on. I know I can help out, but Dr. Reed or Dr. Sprock?
Yeah, so when we're talking about this COVID, we're talking about this coronavirus 19.
Right.
And there are 2 types of tests that are now being done. One is the first and the one that's done most often is a test to see whether or not you have the live virus, okay? And so they do a test, they do a nasal swab, or they look for secretions, and they look to see whether or not in those secretions they can see active particles of the virus. And if that's the case, then that means that you are infected and you can infect others, okay? And what they're trying to do is to determine whether or not you have cleared the virus. Now, if you clear the virus, then they'll look for the viral particles and they won't find them. Now, a large number of individuals that are infected don't ever have any symptoms, okay? And one of the problems with it is if you don't have symptoms, you can pass it on to others and not know that you're passing it on to others. The other type of test that's done, and it's not done as frequently, is a test to see whether or not you had it, okay? And if you had it, your immune system, which is responsible for fighting infections, will develop antibodies against the coronavirus. And so if you've had the coronavirus, you should develop antibodies against it. So a lot of folks that might have had it and are asymptomatic, after 14 days and they've cleared the virus, you won't be able to find the viral particle, but you should see antibodies in those individuals. And that may mean that those individuals, if they have enough antibodies, will be protected if they're exposed to it again, and they might not be able to infect anyone. We don't, at this point, know enough about that yet. We'll learn more about it. But if he's had 2 positive tests, I would say most people clear it within 2 weeks, but it takes some folks longer. It might take as long as 3 weeks. But if indeed the reason that he's not able to work or he's being quarantined is because he has that positive, they probably won't allow him back to work until he tests negative for it. Or they'll see, and some people are even doing the antibody test. But that's usually what they're looking for. They're looking to see that the person has actually cleared it. In most individuals who are asymptomatic, they don't have a second test.
Yeah. Dr. Corey?
Okay. One would like to know what type of test did he have? Because you can still test positive by IgM. What that means, you had the virus and it's not yet cleared from your body. It means there could be 1 or 2 little big pieces that are left. So I would need to know what type of test he had, if it was a screening test or IgM or IgA. That's most important. Because if your IgM is positive, it doesn't mean that you're infected. It means that you may have had, it reflects either current infection or past infection. And after the IgM, you have to look at the IgG. If the patient develops antibodies, they're presumed to be immune. How long that immunity lasts, we don't know. In terms of his work, what I have found from my practice is that every job has their own requirement, but the CDC has set out certain recommendations, because if you've been tested, treated, and been on quarantine, you can return to work, but every day when you go to work, you have to have your temperature done. So again, it depends on what the job requires. If the job says you have to have 3 positives, 3 negatives, or a negative one, that's what you have to do in order to keep your work.
Right.
That's it.
And also, I think it all depends on the person's immunity.
That's
If you have an immunity that may be compromised for some whatever the reason, be it diabetes or be it some other ailment, you may not be able to clear the virus, or you may test positive longer. Now, this obviously hasn't been proven because the virus we've only been experiencing this virus for a couple months now, and we've yet to learn so much about this. But yes, testing positive several times is a problem because, true, employers will not let you come back unless you test negative. Go ahead, Dr. Lee.
I just have a question for you, Dr. Bay and Dr. Sprott. May help this person. Can you comment on the asymptomatic patient, say a healthcare worker who abides by healthcare precautions, wears a mask, frequent washing of hands, social distancing, asymptomatic positive test? Do you think utilizing the tools that we have with mask wear, the N95, as well as gloves when appropriate and frequent washing of hands can prevent the spread of the virus in an asymptomatic individual who tests positive?
All right. I think it can help prevent if you take those precautions. Now, there are two different things we're talking about here. You're talking about a positive test, not someone who's been exposed. That's two different things. If you're someone who's had a direct contact with somebody who has the virus and you were not wearing appropriate protective gear for that person, then you are a direct exposure. That person needs to be quarantined for 14 days just because of exposure. Now, if you test positive for the virus, that you come under the category of being isolated because you're positive. And it doesn't matter if you're asymptomatic or not. If you test positive, then you should be isolated because the possibility of you spreading the virus is there. Because the blood has been tested in the blood.
Absolutely.
So the difference between quarantine and isolation is two different things. Now, if somebody tests positive and they're symptomatic especially, then they have to be isolated, meaning that everyone who goes into that room should wear appropriate PPE. They should have their own separate part of the house, an own room from the house, and not be associated with the rest of the family, if possible. So those are the type of things. There's quarantine and then there's isolation, and those are the criteria that I understand from the CDC. Dr. Sprott, can you, or Dr. Court?
I agree with you, Omar.
Yeah, I'm the CEO of a hospital that has a vulnerable population, and we went through a major challenge for 2 weeks. And so we went through all of that. But I think what Dr. Lee was asking about were asymptomatic individuals and what may happen there. I think that when you talk about, and this is an important thing relative to the mask, if you will, understand that nothing is completely protective, okay? We talk about mask, the N95 mask, and what that 95 stands for is 95% of particulate matters can't get through. That doesn't mean all, but indeed the N95 masks are designed to prevent individuals from getting the infection. So those individuals that are healthcare workers in my facility that are taking care or took care of patients, because we now, thank God, don't have any more patients that are infected. But when they were in contact with individuals that had tested positive, had to wear the N95 mask, they wore the shields, they wore the gowns, and so they consumed a large amount of protective equipment. Most of the individuals that you see walking around aren't wearing N95 masks. They're wearing surgical masks that are designed to prevent individuals who may be infected but are asymptomatic. Because a large number of individuals, they say maybe 80% of the individuals that are infected never get any symptoms, okay? But they indeed can expose other folks, and especially if they come in contact with someone who has, you said, immunocompromised or are old. The overwhelming majority of individuals that have died from this infection, especially in the state of New Jersey, have been over the age of 65, many of them over the age of 75. and many of them in nursing homes. Over 25% of all the deaths in New Jersey are in individuals that were in nursing homes. And those are individuals that probably got infected by, healthcare workers, or from, if they were going out, because some folks go out and come in contact with it, and then get very sick and die. So if you're talking about, what you can do, individuals that are healthcare workers, I'm sure that had the best practice and everything else, got in contact with and got sick. And some of them have died, although the overwhelming majority have not contracted COVID, even though they were in contact with individuals that were infected. And so, as you said, if you know that you've come in contact with someone who has a coronavirus, you should get tested. Okay, you need to isolate. You should get tested. And you usually should go to your doctor. The doctor will ask you to go get tested. If you're tested and you're tested negative, okay, you might want to get tested a second time, because again, for the very first couple of days that you might have been exposed, you might not be able to test positive until you start to test positive. And once you test positive, then you're going to want to be isolated until you're clear. And as you said, that time frame can either be 2 weeks or 3 weeks. But I think that for the most part, we are concerned still. In New Jersey, it's there've been over 1 million folks tested, but vast majority of those individuals have tested negative, which means that there are a large number of individuals still that are susceptible to getting infected if they're exposed. And the idea of the masking is designed to keep those folks that might be infected and asymptomatic from spreading it, because they can't spread it, because you're talking about the social distancing of 6 feet. Remember that if that virus is in your nose and throat and you have it, it's got to get through that mask in order to get to someone else. And the way that other folks get infected is through that exposure. And one important component of your getting it is how much of the virus are you exposed to? If you're in the same room in a closed space and there's not ventilation, there might be a lot greater exposure than you're outside. The ability to get infected becomes less. So I think it becomes important that if you're going to be out and about, you want to make sure that the folks that you're out and about with has masks, because even if they have it and they're asymptomatic, it's unlikely that they're going to spread it to you. But if you're going to be walking around with a whole lot of folks that don't have masks, I would be concerned, especially if you're my age, because I know that there are people out there who may have it, didn't intentionally want to get infect you, but indeed are doing it.
I know we're spending a little time on this particular topic, but we're getting a lot of questions about this topic. Let me just explain. I'm a critical care doc, and I see these patients in the ICU. Let's just go over a few things. There's a few things that I think are important as far as COVID is concerned. Number one is that there are certain organs of the body. Well, let me step back for a minute. There are certain diseases that seem to be that COVID seems to gravitate towards. Number one is being overweight or obese. It seems to be one of those diseases or one of those problems. High blood pressure as well as diabetes. So if I think about that, then if you're overweight or if you're obese, the likelihood that you're going to have diabetes or hypertension is increased. And thinking about inequalities in our neighborhoods, definitely we're a target, because those are some of the diseases that we are affected with most. Also, as far as different organ systems in the body that the COVID virus affects. Number one is we've found that the lung it seems to be a primary target of this particular disease. Why? We're still trying to figure that out. Also, what we're finding is that once someone has severe effects of the COVID, usually their kidneys are affected too, and a lot of the patients have to go on dialysis. The third thing that we find is that there is an increased clotting in the blood. And a lot of patients have what we call pulmonary embolus, which is the clots in the lung, or a deep venous thrombosis, which are clots in the vessels of the leg, or strokes, where the blood vessels of the brain get a clot, and then people are having strokes as well. And also the liver is affected. The liver, we usually have the enzymes of the liver are very high when these people, when patients are severely ill with COVID. So these are some of the things that we are finding, and the problem is that once the disease takes hold of the body, it's up to the immune system to be able to counteract that virus being replicated very fast. What we think is that there is a hyperimmune status, meaning that our body, for some people, I think their immune system tries to catch up. The virus is replicating so fast, and the body tries to rev up its immune system. Those little antibodies that help protect us from diseases, rev those up really quickly, and we get what we call a hyperimmune response, meaning that the immune response in our body goes so fast and gets so big that immune response actually hurts the body as well as trying to help it. So there's still a lot we have to learn about this virus. There's a lot we have to know as far as trying to get medications, trying to get a vaccine, but we can get through this. Just everybody hang in there. Facial distancing, distancing is very important. Face masks are very important. Washing your hands for 20 seconds, very, very important. Does anybody else want to chime in on this? I just think we should.
Yeah, if I may chime in here, this is Dr. Aluya. The paramount thing about the COVID-19, it's the disproportionate manner of which is affecting people of color. And that's a big issue, especially when it comes to people who look like me. And why is it that affecting us far more than anybody else? There's a whole constellation of reasons. And why are certain organs more involved than others? Again, there are a whole lot of postulations and results and reasons for that. And COVID-19 is a disease in evolution. It's novel because
you're on mute, Nelson. You're on mute.
You're on mute, Doctor.
Right, and there are about 10 of them, but 3 of them are the ones that really affect human beings. We've seen all 3 right now: the MERS, the SARS that came out in 2003, and then the COVID-2, the SARS-2, which is the COVID-19, named after the year it was found, 2019. Why is it why is the lung particularly a target? And that's the reason. There's a receptor, because for everything to go into the body, it has to have a receptor site that it attaches to. And that receptor site that we know in human beings is called the angiotensin receptor.
You're on mute again.
Mute.
And the angiotensin receptor site is the site. And it's really very high in the lungs. We also have it in other organs as well, but so much higher in the lungs and the upper airways. And that's the reason why, as the virus gets into the upper airways, it goes straight to the lungs, it attaches to the lungs and all that. Now, why is it more in those individuals you've just described, diabetics, obesity, heart disease, kidney disease, and all that? It's because we have an upregulation of the ACE receptor, that's angiotensin converting enzyme receptors 2, in those individuals. So chronic medical issues or chronic medical diseases have upregulation of those enzymes in those individuals. Now, the question is, why is it more in blacks? Probably we have more. Some people have said that, but there's a huge dichotomy. I'll come to that between blacks here in the US and blacks in Africa, because like I said, 190,000 people are expected to die in Africa, but we're not seeing that yet. And they're blacks. But then we have blacks here and even the Caribbean. Why are we not seeing that amount of death? There are reasons for it, and there are postulations. And it's important that we get to know this so that we begin to protect our brothers and sisters who are across on this side of the Atlantic as compared to those on the other side of the Atlantic. Now, why is it more in blacks here in the United States? Because 1, healthcare disparities is a big issue. That's 1. 2, we have a high proportion of obesity, diabetes, heart disease in each and every one of the individuals that are black or people of color in this environment. So obviously, if you have that, and now upregulation of those ACE receptors in those individuals, of course, you're going to see that it affects them more. Now, what do we do about it? you know, the whole this social distancing and everything else, those are the things we need to take care of. Now, why is it that we're not seeing the same thing in Africa and the Caribbean? One reason, Africa has the youngest population on earth. If you count countries with the youngest population on earth, 1 to 30 are all in Africa. 1 to 30 are in Africa. So they have younger population, less obesity, and of course, if they have younger population or less obesity, the propensity for them to have heart disease, you know, diabetes, and everything else is much less. So you don't have that much upregulation in those receptors in them. That's one. Two, a huge population of vitamin D and the COVID severity of COVID. Now, studies have shown that a lot, in fact, across Europe and even here in the United States now, you know, Northwestern has done a huge study on that, where they try to find out why are people sicker than others. One of the things they found that the people who died or people who are really sick who ended up in ICU had a much lower, you know, vitamin D level than, you know, the rest of the population. Now, what does that mean? Does it mean that we need to, you know, start hoarding vitamin D? No. However, it's really important that we must check our vitamin D level. In my practice, and I've shown all the other doctors' practices, we've seen very low vitamin D levels in those people of color. Why? Because we need to come out in the sun to get vitamin D. Now, for those who live up here in the Northeast and the northern part of America, where we have a huge amount of, you know, months of winter, the winter puts people in-house most of the time, and we don't get that amount of sun. And of course, we don't go out, and we, people of color, need more vitamin D exposure with the sunlight, because that's what you get the vitamin D from. Your skin produces vitamin D when you're exposed to the sun, and that's just the way God did it. Now, we need more, but because we don't have more, we have less. So that, again, puts us more at risk. So if you compare both, you know, brothers and sisters across the Atlantic, you find out that in Africa, they have sun. It's summer almost all right year round. So the high vitamin D is high. They do more things out in the population. So they have high amounts of vitamin D and less, you know, severity of the disease.
All right, excellent, excellent. Does anybody else want to chime in? We're going to.
I have a question for Nelson.
Yes, go ahead, Dr. Court.
Is there any correlation between the vitamin D levels and the fact that if the levels are high, the patients tend not to get the pulmonary complications? Is there a relation between that and angiotensin, the enzyme?
In all societies, most of the studies I've seen, you know, compilation of studies, high vitamin D does not prevent you from getting infected. You will get infected, but however, what it does actually, it upregulates, I'll use the word, enhances your innate immunity. That innate immunity, you know, the T cell level, the natural killer cells, the B cells, and again, it shows that it downregulates the cytokines. Those are the big, you know, things that results into, you know, the immune system going haywire and going crazy, that results in the severity of the disease. So that's what vitamin D does. So the higher amount of vitamin D you get, the better you're able to handle the disease. Is it 100%? No, because if you have more confounding medical problems, maybe severe heart disease and uncontrolled diabetes and all that, you may still be sick or you may still die, but the chances are much less.
Can you comment on the role of vitamin C?
Yeah.
Well, in our society, vitamin C, it's one of those, what do you call it, water-soluble vitamins that you get that helps with cell buildup and healing. So if you have, of course, people who have asthma or people who have COPD or who smoked, they have some, you know, breakdown in the cellular component within the lungs or everywhere else. So vitamin C really does help with that. However, it does that better in the place of zinc. So if you have a combination of zinc and vitamin C, your healing process is so much more. And it's an anti-metabolite, so it's also helped, you know, with cellular burst of viruses. Now, you know,
Nelson, just since we didn't have access to remdesivir, we didn't have access to the hydrochloroquine, we put our patients on zinc to try and mitigate the issue.
Right.
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 Whether or not
Yes.
it worked or not, we didn't, but we knew it had antiviral, and I think we did relatively well with our patients.
Right. Yeah, I know.
But
With the
if I may say something quickly with that zinc, because it's so important, and people say this a lot. And the reason why, the whole study on the zinc came out, because this whole study was actually done with the SARS-1, which, was the first one that came out. And a few studies that came out in MERS showed that zinc in the presence of virus actually inhibits a couple of structures. And that's why the whole hydroxychloroquine components actually came up about as well. Now, there are 3 components of level within the cell that it works. Now, with the zinc, it actually inhibits the cell replication of the virus within the human being. So that's how it really works.
Yeah.
I want to just a word on the testing
regarding vaccine.
Hold on. Who's speaking?
Regarding vaccine.
Dr. Sprout, let Dr. Anderson speak, and then we'll come back right back to you. Go ahead, Patrick.
With respect to developing a vaccination platform, there was talk of a German study using the BCG platform. Do we believe that people who are inoculated against TB, when we talk about people in the Caribbean and Africa, folks who receive BCG, where the thought was the immunity lasts 20 years or more, that people who are tend to do well with coronavirus have something to do with those people who have received BCG against TB?
Patrick, it's possible.
As a matter of fact, a huge study has been done, because almost all of people in Nigeria is the most populous black country on earth, and everybody gets a BCG. And again, what does the BCG do? 2 things. We have found that here in the United States that a lot of people who got really sick were people who never had a prior primed immunity. So meaning, here in the United States, we've succeeded in killing almost every bug. If you take the biomatter of the average American here, and those in the Caribbean and those in Africa, Africans have a biomatter of 5,000. The Caribbeans have a biomatter, or Latin America, or the Americans have a biomatter of 5,500. The biomatter of the average American is 500. So there's no prior exposure to an immunogenic stimulus that's ready to hold on to anything. So once you get exposed to this virus, who is novel, nobody's seen it before, nobody's experienced it before, no immunity has been produced. So those individuals who got really sick are those who wanted a way to, their immune system have been put in hyperkinetic state in order to fight it. So meaning like, hey, there's something here, we need to take care of this, we need to take care of this. So they have to regroup all of the immune system that they have. Now, what the BCG does is actually, it stays, like you said, 20 years it lasts for. There's a ready-made innate immune readiness that is there. So the hyperkinetic, otherwise called the hypercytokinetismia, is much less in those individuals. And that's the reason, suggestion for it.
All right, that may have been over the heads of some of us, but
I know, right?
we have to break it down just a little bit more than that, okay, guys? I think we're going to move on from this question. I know that's a question for many people. I've gotten so many questions coming over through the questions about this, but we're going to move on.
Hey,
Omar,
I just want to
I'm sorry. Go ahead, Doctor. Dr. Sprout. Go ahead.
Just a word of caution. Somewhat related to what Nelson spoke about and what Dr. Court spoke about. When I talked about the 2 different types of tests, one is to look for the active virus, and it's specific for the corona or the COVID-19. When you're talking about the antibody tests are looking at antibodies, IgG, IgM, and IgA. They're not necessarily specific for the COVID-19. And so there may be some individuals that might have antibodies against other coronavirus, because some coronaviruses just cause upper respiratory tract infections. So we don't know yet whether or not these antibody tests that are being developed that supposedly are supposed to tell you whether or not you are immune to coronavirus 19 are actually specific for coronavirus 19.
All right. Okay. Thank you. Thank you. I just want to take a break just right here, and I should say a pause for the cause, just to let you know that number one is that we plan to do this the second Saturday of each month, and we will be here 1 o'clock the second Saturday each month. Whatever that date is, we're going to plan to be here and answer your medical questions. Again, I'm going to state, we're not here to change your doctor. We're not here to be your doctor. We're here for your medical education. That's it. The most important thing to us is that you become better healthcare consumers. You're able to take care of yourself because you understand the basic problems that we as African Americans have, or descendants of Africa have: high blood pressure, diabetes, heart disease, kidney disease, that lung disease. We can understand it better so we can take care of ourselves. So don't change any aspect of your medical care until you consult your physician. And I say that each and every time because we're all different, and a medication that may be fine for me may not be fine for you, and your doctor is the one that knows you best. Again, I would like to say, listen, it's so important. It's so important what we're doing. I want you just to tell people about this. This is our first week, and obviously it's just getting started, but we need to tell our friends, our sororities, our fraternities, Jack and Jill, the Links, whatever organization you're in, the Masons. Tell people about it. We're here. We want to answer your medical questions, and we want to answer them from a Black perspective. Okay. I think that's enough right there. Let's go on. Dr. Anderson, there's a question that came through. I know we are who our parents are, all right? And I think they're talking about their genes, okay? But is there a way that we can change the bad outcomes of disease like ovarian or uterine or breast cancer with the knowledge that we have at this particular point, all right?
I think I'm going to drag Kevin into this somewhat, but I'm going to take a go at this. I think with respect to cancer and many other diseases, as we saw through the whole Human Genome Project, we're realizing that there are many disease syndromes. And as it relates to cancers, there are many cancer syndromes. And as it relates to female cancers, such as breast, colon, ovarian, and many of the genital tract cancers, there can be syndromes as it relates to single diagnoses or clusters of diagnoses. So for example, to name one syndrome, the Lynch syndrome, which covers a broad group of cancers and covers cancers in both genders. This is where you have what's called hereditary non-polyposis colon cancer, where the spectrum of disease relates not just to colon cancer, but also relates to prostate cancer in male relatives, but also ovarian and uterine cancer in relatives. Now, there is genetic testing that identify individuals at risk. So we are used to traditional screening for many of these cancers, colonoscopies for colon cancer, mammograms for breast cancers, but no real screening tests for uterine and ovarian cancer. So identifying people who are genetically at risk, and I use Lynch syndrome as one, but there are many others. If you know through genetic testing that you're at risk, then you can make some lifestyle changes. For example, fertility. Part of our cancer survival spectrum is fertility sparing. So one can be counseled as to when and how to preserve fertility. One can be counseled as to how often one should see their physicians. One can be counseled as to what questions to ask. As important as that, recognizing that genetic screening does not help us prevent you from getting the cancer, because we're not at the point yet where we can manipulate genes to now reverse the potential risk, but at least we can identify individuals who are at risk and take them out of the regular protocols for screening that we use for the general population.
Mm-hmm. All right. Kevin, can you help us out on some of this?
Sure. Like Dr. Anderson mentioned, it's a little bit complicated. Just because you have the gene doesn't necessarily mean you're automatically going to get the disease. So it's not always one-to-one. There are a lot of factors that play a role in terms of whether or not, even if you have the gene, you will subsequently get the cancer, or actually any disease process in general. There's certain cancers that we know where the relationship, once the gene is present, your lifetime risk is such that we have to institute either preventative treatment or things that can attenuate that effect. So for instance, I'll use breast cancer, the BRCA gene, breast cancer gene. You have a lifetime risk dependent on if it's BRCA1 or 2, anywhere between 40 to 80%. In that setting, we recommend we offer different options. So you can have a treatment to decrease the effects, which is chemoprevention, or we can offer an operation which will essentially cure you of breast cancer, which is prophylactic mastectomy. And there are other cancers where we do the same thing. So colon cancer, as Dr. Anderson had mentioned, Lynn syndrome, and there's another one called FAP, or Familial Adenomas Polyposis. It's a lot
of big words.
Complicated, but basically, it represents a situation where you have a gene, a mutated gene, and because of that gene, your risk of developing subsequent cancer is extremely high. And in those situations, we have to, it's more of a direct relationship, and we tend to offer more prophylactic surgeries or measurements in those situations.
All right, thank you, thank you. Dr. Lee, there's a question here. I have severe back pain most of the time. What do you think it's from? Number one, is there an effective treatment or other than surgery? And then at the end, he says, help, exclamation point.
Yeah, so that's probably the most common consultation you'll see in an outpatient orthopedic office or even a primary care doctor's low back pain. So just to take it back, if you look behind me, you see these bones lined up here. That is an example of the spine. And so in the low back, there's called vertebra. There are blocks, and in between those blocks, there's called discs, and those are cushions. Right next to those live the nerves that basically control your legs, your feet, and the muscles, and so forth. What I commonly see in a community orthopedic practice are age-related changes in the spine. So as we age, our bones change, our muscles change, and the surrounding nerves and so forth can sometimes be pushed upon by these bone changes called bone spurs. So a bone spur is essentially a bone's adaptation by making more bone in response to stress. So as we live life, we run, we go up and down stairs, we lift things, the anatomy changes. And unfortunately, sometimes the surrounding anatomy is affected in such a way that it can cause pain. And so things that we look at to differentiate the pain are, does the pain go down your legs? Does it stay in the spine? And that oftentimes can tell us what is being affected. Is a nerve being pinched? Is there just local arthritis? Or where the spinal cord ends, sometimes there can be narrowing called stenosis. And so when somebody has back pain, these are the things we try to figure out. How we do that is a good clinical examination. We check the reflexes, we check flexibility, we check strength. And then from that point, we try to come up with a laundry list of what this could be. And so many of us have heard the term like a disc herniation or slip disc. The disc itself between those blocks that I mentioned is mostly water. And over time, they can dry out. And even sometimes with trauma, that water can leak out. It's almost like that gum chiclet where you have that little soft center in the middle. That disc can sometimes push out. And so back pain can be very frustrating. I will say that the majority, based on research, the majority of routine back pain will go away within 3 to 6 months, oftentimes not needing a major intervention. Oftentimes, what I will recommend is physical therapy, where we work on the core muscles in your abdomen and your low back, flexibility, making sure that we've done our appropriate X-ray or a diagnostic study, and then follow up. What I will say are red flags would be nighttime pain, weight loss, severe pain that doesn't respond to high-level medication such as narcotics, because then we have to think about, okay, is there something else like a fracture, or is there maybe even a tumor or something along those lines? So I hope this helps. It is a frustrating problem. What I would recommend is making sure that you know that cause, why it actually is there. Learn about what the anatomy is, and then know the majority of time back pain does respond to conservative measures. I'll also list briefly, if the physical therapy doesn't work, I'll use the analogy like going up a ladder. At the bottom of the ladder, you have rest, medication, physical therapy. As we go up the ladder, we go into injections, and then at the top, sometimes a surgery, which is pretty rare.
All right, thank you.
Would things like turmeric or CBD help in those type of pains?
Yeah, so that's a great question. So turmeric, it's a long-known anti-inflammatory that can be taken, by mouth. CBD or cannabidiol, it works on multiple receptors throughout the body, including pain and inflammation. So to answer your question, yes, I find that CBD locally, the oils, can help with some of the muscular-related pain that people experience, in the low back, and the turmeric is a good anti-inflammatory.
All right. Well, thank you. Yes, yes. There's a question that came through. I'll try to read this. Blessings and good day to all the doctors. My name is Miss McKenzie, and I have lupus. My system is already on high alert and overreacts to small cuts. I take immune building natural remedies. Should I continue due to my system already on high alert? I think some of the internal medicine docs, or even Dr. Patrick Anderson, you are one that is keyed in on things like this. Lupus is an inflammatory disease that where the cells, or where our bodies are, the best way to describe it, I guess, is that we attack, our bodies is attacking itself. Dr. Sprott, can you lead off, and maybe some of us, some others can chime in, or Dr. Aluya, as far as lupus is concerned and some of the things that we should be concerned about? And maybe you can explain just a little bit, very short, what lupus is.
Well, I can start. It's, as you indicated, sort of an autoimmune disorder. So auto means to self. Immune means that your immune system, which normally is designed to fight infection or to fight cancer, starts to attack normal cells. And it can start to occur in children as well as in adults, but you can have issues of arthritis. You can have, some folks have something called discoid lupus, which sort of affects the skin. But one of the organs that really can be devastated is the kidney. And so a lot of the treatments are designed to fight or deal with the inflammation that's associated with these antibodies attacking the tissue. And some of the medications that Dr. Lee talked about that are used to treat arthritis are also used to treat lupus. So steroids are used, as well as other kinds of medications to try and stop what normally happens. They have these exacerbations and remissions. So when you say it revs up, the antibodies start to get higher, the attacks start to occur. If you have arthritis, you start to have more arthritis, and then it starts to go down on its own. But some of the other drugs that are used, and this goes back to an earlier question, are some of the chemotherapeutic drugs that are used to fight cancer, that also tend to help suppress the immune response and lessen some of the issues. But it can be a debilitating disease, and I've seen a number of adolescents and young adults who have died from complications associated with lupus. Very serious.
Anyone else who want to chime in on that one?
Well, if I may chime in, just like you said, it's an autoimmune disease where the body fights itself. Basically, that's what it is. And the whole lot of, cells that involved, complements. Those are small bodies that infect, including the so-called cytokine that's causing trouble with the corona now too. So you do also have a cytokine storm in lupus disease as well. It does happen. So it's the process where something really just stimulates the body and it goes haywire and starts producing, antibodies that fight itself, and they all, aggregate together and form complexes. And those complexes can get deposited anywhere from the brain, where you have lupus cerebritis, and it happens really devastating disease, to the heart, to the kidneys, and to the skin, like the great doctor just said. And it affects almost every, tissue, including the joints, where you have, joint affectation as well. So, but particularly if somebody with lupus, one, you have to have a great primary doctor who, will follow you up as often as needed. Two, you have to have a rheumatologist who would, basically drive, the management of the disease in conjunction with your primary care, who will make sure that all the medications that they're giving you are not causing other complications as well. Because sometimes you may treat one disease and end up with another. Maybe you never had diabetes. Now the treatment for lupus, you're treating the lupus, but then now you have diabetes. That has to be treated as well. But if you don't, then it makes the whole disease complex even worse. You have to have an eye doctor who makes sure your eyes are good, and a heart as well, to make sure the heart. And then you have to keep an eye on the kidneys, because the kidney is wholeheartedly affected by, by lupus. So with simple tests, you check your urine, make sure there's no protein in urine, or albumin. Those are small proteins, I call them, that can get spilled up in the kidneys, and we don't even see that. So checking for all of these, and if you have them there, you may take the ACE inhibitors, like Dr. Court has said earlier on, that protects the kidney as well. So all the combination of all that, it's a multi-organ system that needs multi-specialty care.
All righty, thank you. There's a question that came in from I think this, and then Dr. Fredericks, I'm gonna drive this one towards you. I'm an African American female that is overweight, and I love my soul food. That's what she says. Since being obese increases your chance for getting COVID, how can I lose weight in a healthy way?
Wow, that's a good question. Because weight is really a manifestation of what we're eating, right? And so in order to lose weight, we have to be able to eat better. And weight is kind of funny because it's not like a scale, it's really like a thermostat. And when you eat and it sort of rises, the body monitors that. And so when it gets past a certain point, that's when we realize, oh, I'm a little too heavy and I want to lose that weight. So you lose that weight, and then the body fights you to gain that weight back because it thinks that's where it's supposed to be. And so the body will then secrete certain hormones that get you hungry, and you'll start to eat that and bring it right back up. So it's always an up and down type of thing. In order to lose weight, you have to now be able to eat consistently healthy in order to lose that weight. And I know, being a soul food, any food can be made really well, right? So we really have to cut back on those highly caloric foods, all right? The sugary foods and things that are going to have a lot of calories. And so what we really need to be eating are more nutritionally dense foods. For example, if I eat something that's highly caloric, it tends to be really dense with that calories. And so it may be like small, like an M&M or cookie or Oreo cookie. That's nice and small. But eating something that's nutritionally dense, as opposed to being calorically dense, those tend to be things that, like vegetables, broccoli, something like that. That's calorically small, but nutritionally dense. So if I eat, I don't know, 500 calories of a cookie, that's going to be small, and that's not going to really fill up your stomach. Eating something that's calorically, nutritionally dense, that's going to really fill up your stomach. And so you have to eat things that are going to really keep you full and satisfied, and are not going to have as much calories. So when you come to stuff that are high in soul foods, I love my soul food too, but anything could be made good to eat, okay? Despite what we're eating, we need to eat less of that highly caloric foods. And we need to eat more of those highly nutritional foods in order to lose that weight and consistently keep it off, because our body is always going to fight us to get it right back up to that level.
Right. I think also they're talking about.
Ask a question with respect to weight loss surgery, the psychological counseling that goes into it, because I feel that the one thing that has not been addressed is psychologically how we depart from eating to survive, to gain energy, but eating for satisfaction, and that satisfaction as it pertains to taste and pleasure. So can you discuss separating pleasure of eating versus pleasure for fuel in order to function?
But what weight loss surgery does, it prevents you from eating past that point, okay? For example, something like a sleeve gastrectomy that limits the amount of food you can take in. You can only eat so much and you'll feel some discomfort. And so now the behavioral aspect is key. Now you have to be taught to recognize, I'm full, I should stop eating. Some of these procedures kind of force you to do that. That's why they tend to work initially. But a person who does not change their way of eating, they can now consistently eat that sort of stuff and sort of stretch back out those intestines, that small bowel. It'll never get back to the original size because you will feel that discomfort. Okay, does that make a little bit of sense?
Yeah. Oh, yeah. Oh, yeah. Well, also I think that, the psychological aspect of food for especially, in all cultures, but I think especially for African-American cultures. I mean, food is associated with everything. If we go out to a party, we go somewhere, if we go to a restaurant, we want to go to the all-you-can-eat restaurant. If we go to a party, well, what are they going to have to eat there? It's a kitchen for us, and food is a major component of our culture. So it's very difficult for us to separate that. And then the type of food that we eat, what we love. I'm telling you, soul food is probably the best tasting food out there. But guess what? Let's break down soul food. So you got fried chicken, which has all that grease and all that component to you. You got baked macaroni, which is all cheese and all the starches in it. You got candy yams, which is all sugar. You got collard greens that we're always going to put something in there to make sure that it got that taste and it has some salt in it. So we have all of the things that would help us with developing, help us develop that hypertension, that diabetes, and that heart disease, and that being overweight. So we as a culture have to pull back. In my weight loss program, I have 3 things that I had to realize when I put the program together. Number 1 is that you have to commit.
You have to commit.
Stopping smoking. If you don't commit, guess what? It's just not going to happen. So you have to commit to it. Number 2 is you had to find out to develop a program that did not make people feel that they were being punished. Because if you feel as though you're being punished and I can't eat this, I can't eat that, I can't eat this, well, guess what? It's not going to last. And the 3rd thing was to get them to realize that we all have our own individual metabolic rates. And it's so important. How fast do I burn calories? We're all different. I may be a person that can eat 3 meals a day and stay thin. Another person eats 1 meal a day and stores half of it as fat. So we all have our own metabolic rate. So when you come to the realization of how you should eat to maintain the weight for your height, then that's a lifelong process. And it's just the way it is, like a diabetic has to take their blood sugar. Understand, someone may have to cut back on their carbs. They may have to eat more salads. They may have to eat more vegetables. They have to do what they have to do to stay within that healthy range of weight. That helped out as far as
is a chronic condition. It's a chronic condition.
Right.
So you have to treat it like any other chronic conditions.
So true. So true.
Omar, do you have a diet sheet, a diet recipe utilizing soul food in your book?
Actually, we do have a recipe and a diet, sort of a suggestions that how to appropriately go after a great meal of soul food and still maintain a calorie range. And one of the things that we recommend is a large salad before you start. Understand that the salad is great because it has, lettuce and things like that. It has 95 to 90% water, 97% water. So it has great nutrients, it has great vitamins in it, all of that stuff. But if you eat a salad before your dinner, a large salad, you're half full before you start. And then if you cut the meal in half, meaning that you cut your carbs in half and the sugars in half of your primary meal, but maintain the proteins or whatever your meats are for the appropriate size, guess what? You just cut your calorie intake in half for that meal. So that's some of the things that we recommend, Dr. K, Dr. Court, in the book.
Yeah, having that fiber is key. Having that fiber and that protein.
That protein is key because that fills you up and it metabolizes slower. So you don't get hungry as fast when you have the fiber and also the protein there as well. Mm-hmm. Any other questions? Yes. That was great. Well, the thing of it is that what we have, I have a question on it relates to diabetes again. Please explain insulin resistance, all right? What is going on in the cells at that particular time? Can either Dr. Sprott or Dr. Aluya help me out with insulin resistance?
Yeah, I mean, insulin resistance is partly what I spoke about before, is that, and it's usually related, I'll say, to weight or really body fat composition. The higher your body fat content is, it appears that the more insulin you need in order to get that blood sugar down below 100. And so, whenever you eat a starch and your blood sugar starts to rise, almost immediately the insulin starts to get released and it keeps you there. But the more overweight or obese you start to get, then the higher amounts of insulin you need to start to release in order to keep it low. And it just keeps rising and rising. So you might have 10 times the amount of insulin release that you had before you were obese that you now are having. And then you get to a certain point where, again, it's not able to keep it below that, and then your blood sugar starts to rise above normal. And it takes a longer period of time for it to come back to normal. It eventually will get there. And that's what we believe is insulin resistance. We don't know exactly what's going on relative to this change in the increase in your body fat content that causes insulin not to work as much. But again, one of the things I said, metformin, which is commonly used, everything else, that's designed to cause you to release even more insulin, which gets you there, but you're sort of hyperinsulinemic, which you don't want to be. And one of the things that,
hyperinsulinemic means a lot of insulin.
A whole lot of insulin.
Insulin in your blood.
Drain. Yes, and one of the things that they found dramatically is that a number of individuals who were morbidly obese, who were diabetic, as their weight started to fall and their body fat content started to fall, their diabetes went away.
Right.
That's not the primary treatment, but it was sort of a side effect. And I think people just need to understand, if you are obese or morbidly obese, you are eating and exercising to keep you at that weight. You are maintaining that weight. And so if you want to lose that weight, you need to do something differently to your level of activity and the amount of calories that you're eating. And when you look at, exercise, and you look at the amount of exercise you need to do in order to lose a little bit of weight, it's astronomically larger than what you can do if you decrease your caloric intake. So for me, if you're looking at trying to decrease your body weight, the most important thing is to make a decision, and that decision ought to 99 out of 100% of the time decrease your caloric intake.
In fact,
there are lots of things that are being tried, and some of it sort of works upon, to a large extent, insulin. Insulin is a primary, when you talk about this hyper amounts of insulin, one of the things that insulin does, in addition to promoting sugar to go into into cells so it can be utilized, it promotes the storage of fat. And so when you're hyperinsulinemic, you are just, you're hyper set up to gain fat and to gain fat and to gain fat. So part of the trick, if you will, or one of the important components is to reduce the amount of insulin that you need to have released by focusing a lot on how much starch or sugars that you're eating. So if you can sort of not eliminate them, but modify them. The other aspect is, and a lot of attention has been paid to this, is this intermittent fasting. You know, if you're gonna fast, you stop, you say, okay, I'm not gonna eat anything. Well, you start to lose some weight, and then your body will start to adapt and say, I'm gonna slow my metabolic rate so that I don't lose, I'm conserving things. So if you can start to create this intermittent fasting where you eat for a certain period of the day, let's say from 12 to 6 or 12 to 7, and you stop at 7, at a certain point, you'll eliminate all of your blood sugar, you'll get to a low, and then you'll start to catabolize and break down fat. And then if you don't eat until 12 noon, you're breaking down fat maybe for about 8 hours, and you'll start to lose weight, especially if during those 8 hours, you don't just go hog wild and eat a whole lot of food. And so what you talked about and what others are talking about is you need to develop a new norm. You have to change the way that you're eating, and you need to change it to something that you can stick with. Because once you get to whatever size, let's say that you're 300 pounds and you want to get down to 150 pounds, you want to stay at 150 pounds. So once you get to 150 pounds, you need to keep the caloric intake and the level of activity the same. Keep you at that. If you start to eat more, then all you're going to do is get bigger. And the same thing with the gastric sleeve. You know, it restricts the amount that you can eat for a couple of years. And then if you eat a little bit more, then it stretches and stretches and stretches. And then you end up eating more and more, and you're eating twice as much or 3 times as much as you were eating when you first had the surgery. And then you gain it back.
So true, so true.
I want to add with the gastric bypass, when they do the bypass portion, right on the table, we see the insulin levels drop. So right away for a patient that's a brittle diabetic, the cure is actually a gastric bypass, because that's what the Endocrine Society now recommends, that a patient that's a brittle diabetic to get gastric bypass, because it has, of course, diabetes.
All right, thank you. You know, we got about 10 more minutes left. So, but I want to try to get to as many questions as possible here. There's one question. I've had leg swelling, and it was discovered that I had blood clots. Can somebody address that? Blood clots in the leg. I mean, that is something that I think we in the hospital, and all of us during the hospital, have had patients that have had that. Can we start that off? Dr. Anderson, I know you're a surgeon, and blood clots is something that you always worry about. You're on mute, Doc.
Yes, I got it. Well, you know, blood clots is often a result of many factors. One of the common ones we deal with is conditions that that are sedentary. So, for example, patients who are on long plane rides, long car rides, where the blood does not flow well from the extremities, meaning the hands and the feet, back to the heart and get circulated, these bloods can clot. So there's a somewhat physical aspect to this. And we see this in patients who are morbidly obese, patients who are hospitalized for a long period of time, patients who undergo surgery, with guys like Kevin and myself who are on the operating table for 4, 5, 6, or 8 hours. They develop these blood clots. Patients who undergo orthopedic surgery, long surgery where there are a lot of venous stasis, the patients develop blood clots. There are other conditions, intrinsic conditions, such as many cancers. Many cancers cause what we call a hypercoagulable state. And what that is, there are substances that are secreted by many of these cancers that cause the blood to clot. Now, we tend to focus a lot on clotting in the extremities because those are the more common sites. But these clotting conditions can be devastating because these clots can move to critical organs, such as the lung, and cause the oxygenation to go low, and people can die from this. These clots can go to the brain and cause strokes. Some of these symptoms are like the question mentioned, swelling, but the swelling can occur in the extremities, meaning the legs and the arms, but the swelling can occur in locations that we don't often think about. So for example, if you have a blood clot in the big vein in your chest, you can get neck pain, swelling and shortness of breath. So those are some of the, one of the conditions, clotting, that we consider when we see folks who present with, unusual swelling. Once this condition develops, I think it's critical that one gets a hematologist involved to make sure that the cause is identified. If there's something intrinsic within the blood, something that makes the blood clot spontaneously, there are several studies that can be done to identify the specific factor, and as a result, prescribe the appropriate treatment for it. Some of the things that we do, there are medications that we put patients on, what we call for prophylactic reasons, to prevent this. We often do that in cancer cases, in patients who are going to surgery. Some of these medications can be used in a therapeutic setting. So if there's a clot already, we put them on therapeutic doses. These medications are meant to stabilize the clot so they don't progress. But in layman's term, it basically dissolves the clots. Then there are other things that we put patients on as part of health maintenance. So for example, we often think of a blood clot as an entity that prevents blood flow, but there's other sort of thrombotic or clotting type phenomenon, such as when you have plaque formations, where other components of the blood enables one to develop these clots, which can break off or embolize. And some of these, when patients get put on aspirin, for example, the platelet count can, these cells can clump and prevent blood flow from occurring. And a major aspect of this is patients who develop coronary vascular disease or vessel disease in the heart. These are the basic phenomena surrounding blood clotting in the body.
In addition, medical.
Go ahead, Dr. Cord. Go ahead.
You gave the surgical aspects of clotting. In addition, medically, in terms of what he mentioned, looking for occult cancers, there are other things that you can look for as medical, like certain deficiencies that you're born with. For example, protein C, protein S, antithrombin 3, and factor 5 Leiden. These are kind of rare, but they do occur. And you either need an internist or a hematologist to really assess these.
Right.
The main points are, as Dr. Anderson said, venous stasis, or blood, wherever the blood is moving slow, it increases the predisposition to develop clots. And if you have any damage to the lining of blood vessels or the valves of the heart, anything that's damages, and they call them vasculitis, can predispose to platelet formation, clots to form, and then for them to break off. So it's important, not to have the issues of venous stasis. And earlier, I think, Dwayne, did you talk about the valves of, especially in the lower extremity, to keep the blood from falling back? If those vessels dilate or the valves are not working, leaky, that creates venous stasis, and that predisposes you to develop clots.
Right.
And Patrick, you want to say anything about it around pregnancy that might happen?
Oh, absolutely. That's a condition that, thanks, Dr. Spratt. Pregnancy is one of those conditions where it's a hyperestrogenic state. An elevated estrogen in the body does cause a hypercoagulable state or make the blood clot. But also there's also an anatomic or physical component to this, where as the uterus gets larger, and the sigmoid colon, which Dr. Clark can talk about the anatomy of the sigmoid colon, is on the left, the uterus tends to rotate to the right. And when it rotates to the right, that major vein that comes up through the abdomen and back into the chest, the vena cava, the uterus can sit on that vena cava. And that causes also a physical state where the blood flow sometimes tend not to flow well. Another aspect of it is the progesterone level, which rises in pregnancy, which causes muscle relaxation. So the veins get dilated, and as a result, the blood can pool in the legs. So in pregnancy itself, there are at least 3 major factors that put pregnant women at risk for developing blood clots.
Right, excellent,
In
excellent.
addition, one should not forget COVID.
Right. Yes, COVID, as I stated, it increases the chance for clotting.
And
Yes.
just to add a little bit to that, medications as well.
Yeah.
Estrogen, just like Dr. Anderson just talked about pregnancy medications. Estrogen, those who are taking OCPs, and especially if they're obese on top of it, puts them at high risk. Medications that we usually give to individuals who are cachectic, have lost a lot of weight, like Megace, have a progesterone-like effect that can increase the risk of blood clots. So and those are things we need to be careful about. And if you get blood clot once, if you don't, there's no reason, for the blood clot, either you never had surgery or whatever, it's important to know that you're at risk again. So the essence and the questions I often get, Doc, how long would I have to take my medications? Now, a lot of times, depending if it's just post-surgery or post, trauma, some people have had injury, they're playing basketball, they're playing soccer, and then, they get injured 2-3 months after they develop blood clots. So a lot of the time you may have to take these medications to protect you or to prevent stroke, clots for 3 months. But then, a few people who've had multiple blood clots, they may have to take, those medications for the rest of their life.
Yeah.
And if you've had that one time, I would advise, please tell your family members, because again, in our community, one of the things we don't do, we don't share our medical history. We have to learn to share our medical history so that as we use the mask to protect others, you can also share your medical history to protect your family members as well. Thank you.
Yeah. All righty. Anyone else want to sum up on that one? The thing of it is that blood clots are something that we see a lot in the hospital, and we try to protect the best we can when patients come into the hospital and they're not getting out of bed and they're laying in bed. We have to give them a blood thinner to make sure those clots don't occur. There was a question that came in, Dr. Lee, and I want to find this question. It's about, and we didn't talk about arthritis. The question is, and I just want to state just before I get to that question, because we started a little late, if it's okay with the panel, we'll go over maybe about 10 or 15 minutes. Is that okay? So if it's okay with everybody, then we're going to answer a few more questions because we started late. There was a question, what is gout and what is the best way to treat it? I mean, arthritis is such a common occurrence, and as you get older, Dr. Lee, can you help us out?
Sure. So gout is increased uric acid in your blood, and when that blood crystal, or when this uric acid forms in the blood, it can go into your joints and cause inflammation and pain, and the body reacts with an acute inflammatory reaction, and oftentimes it's very painful. People commonly will say, "Oh, my big toe is on fire," and I can usually distinguish gout from a fracture. In gout, when somebody comes in, they can't even put their slipper on their big toe, and oftentimes we'll test their blood for uric acid levels, and if they have that fluid buildup in a joint, and we look at under a microscope, we'll see crystals, and that crystal formation sets off a cascade of inflammatory events in the joint that really sets the body off and causes severe pain. And oftentimes it responds to medical management. Big picture, arthritis itself, arth, A-R-T-H, like we're talking about a joint, and itis is inflammation. And so it takes many forms. Gouty arthritis is one of the forms that it takes. That tends to be more on the metabolic side of things and can often be related to diet. There also is autoimmune, which we mentioned before with lupus and rheumatoid arthritis. And this is when, in fact, the body attacks itself. And there can be destruction and pain inside the joints. We see it very commonly, say, in rheumatoid arthritis in the knee, but that condition can affect almost any joint in the body. And that has to typically be treated medically, or it can progress. Most commonly is your wear and tear arthritis. That is where you see age-related or In some cases, it is accelerated with injury. So we would call that post-traumatic or after an injury, say a car accident, motorcycle accident, or fall, where the cartilage, the cushion, if you will, inside the joint is damaged. And as a result, arthritis and that cushion effect is taken away. Your routine everyday arthritis typically is treated with a combination of exercise, medication. You know, a big theme of today is weight loss, you know, making sure that you're living a, you know, a healthy life and that you're not overloading your joints. When it becomes, you know, as a surgeon, it becomes a surgical problem when there is an inability to walk or have function, and that individual has been treated with, you know, everything we can try before surgery, as we mentioned, exercise, sometimes injections, medication, and surgery occurs when we replace the arthritis or that damaged joint with a metal and plastic implant, so that when that person walks, they're able to bear weight and not have that bone-on-bone effect that will cause a disabling gait or difficulty with mobilizing.
All righty. You know, there's something,
If I may say something quickly.
Yeah, go ahead, Doc.
On the uric acid and the gout issue, it's something that's very common amongst us. Thank you very much, you know, Dr. Lee, for that great explanation. But a few medications can cause it, especially for those of us who take blood pressure pill. Hydroxychloroquine has a huge risk of increasing the amount of uric acid in individuals. So if you have a gout one time, please look to see if you're taking any of those. Discuss with your doctor. Find out if you're taking any of those medications that can increase the amount of uric acid in you. And again, you know, discussing the amount of meats that you eat. Turkey has been shown to, you know, increase the whole lot amount of uric acid because of the xanthine and the hypoxanthine that it produces. Now, on immediate treatment, gout has been with us forever. There's been, you know, literature, you know, way back in the hieroglyphics where the Egyptians have written about gout. But it's so funny you know, one easy way of knowing if it's gout or if it's cellulitis, because sometimes it's really difficult to differentiate which is which. Is it an infection or is it a gout? I often tell people this: get some ice, put on a plastic case or something. Once you put it on the inflamed toe, if the pain goes away, it is gout until proven otherwise. If the pain does not go away, most likely it's an infection. And it relieves the pain instantly and really does help. I've done that a lot in my office. Thank you.
What about osteomyelitis? Someone had a question about osteomyelitis. Does that play with this ice? You know, putting the ice on the toe.
I want to know what the ice is to make the pain go away.
Osteoarthritis is inflammation, so it's an inflammation from an infection. So if you put ice on it, it may help a little bit, but it doesn't. It's not compared to, you know, the uric acid that's produced, you know, from the gout. Because, like, you know, Dr. Lee said, if you look at that under the microscope, you see the speckles that produce, and they're called negative birefringence, you know, as compared to, you know, another type that is positive. That's a totally different entity. So how does that work? Once you put the ice on it, it actually just condenses those crystals and then coalesce them together, and the inflammatory process that produce is so much more reduced. And that's why the instant relief you get with that.
Okay. Okay. Excellent. Excellent. There is a question here. Please recommend something to build my immune system. I guess everybody's still worrying about COVID, and so many questions about immune system. I think we need to cover it just one more time. Well, I know that there are certain things that I recommend, and just overall, and all the webinars that I've been on talking about COVID, people ask all the time about their immune system. Basically, I recommend a good multivitamin, number one. The multivitamin every day. I recommend vitamin D, the vitamin D3 that you can buy right over the counter, about 1,000 or 2,000 international units a day. also zinc, and we had talked about zinc before, as well as a magnesium. And those are the things that I recommend, about 30 milligrams of each. I just feel that you should have a balanced meal. I think within what we eat, if you have a balanced meal and you're eating a lot of fresh vegetables and you're eating, your salads, and you're taking in your proteins appropriately and not too much candy and sodas. And understand, I've never seen a potato chip tree. So if it's not natural, it's empty calories. It's just calories that you're taking in, but it has no nutrients for your body. What we need to understand is that our body is like my son said, a gazillion cells, but each one of those cells need appropriate nutrients to keep our immune system safe, to allow your body to produce the cells that can protect us. And if we don't get that, nutrients, it won't be able to do what it needs to do. Can anyone else chime in on this as far as the immune system is concerned? Because I think it's important for people to understand, since we're living in the age of COVID.
Yeah,
I just like to
discount the role of rest.
Who's first? Dr. Anderson, go first, and then we'll do second. Go ahead.
Oh, just a brief comment that we should, not discount the role of rest and help one maintaining a viable immune system.
Right.
The only point I wanted to make, Omar, is that there are lots of different natural things that are talked about. But one of the things to keep in mind is that a lot of the problems that you get are not necessarily directly related to the immune system, but with the inflammation that is part and parcel of what happens. And we spent a lot of time talking about the damage related to COVID that was probably part of an inflammatory reaction related to cytokines and others. And so part of I'll say the balance is trying to help regulate or modulate. They have things called immunomodulators that are designed to sort of keep things under control. And as I said before, part of the way that the body works is it tries to keep things in balance. Doesn't always, but tries to keep things in balance as best they can. And so, in thinking about inflammation and how to deal with inflammation, someone mentioned turmeric, and you can take turmeric as an anti-inflammatory, and it may help with some of these conditions in terms of not necessarily preventing your immune system from doing what it needs to do, but maybe not having some of the inflammatory aspects of it that still get rid of the organisms that you're trying to get rid of, but trying to not go overboard. And so you need to keep into account some of the important aspects of inflammation, which can be helpful, but in many aspects are painful and harmful, and trying to make sure that you don't get to the point where that's causing you more problems than the actual immune response.
Right. All right.
A few things, other natural stuff that's been, studied extensively, ginger, garlic, a few other, natural products that are out there. But, the one I recommend the most is exercise. Find a simple exercise regimen for yourself on a daily basis, because the immune system is boosted up, is roused up when you move those muscles, when you move your body. Blood flow to all the tissues, blood flow getting rid of the metabolites that have been produced overnight or all through. So exercise is paramount. And for those of us who are people of color, we build nitric oxide, which is a potent vasodilator and opens up all the vessels and everything else when we move. So it's so important for people of color to move. Thank you.
Yeah. And there's one that I was in the ICU, and the patient's family, we didn't, during COVID, we didn't allow many family members to come up, but one family member got up to the ICU, and they put an onion in the patient's sock. And well, he got better, so I can't say it didn't help. so that's one as well. Listen, we're gonna have to wrap it up here. Let me, in closing, I thank each and every one that tuned in and has tuned in and listened to us. I just trust that you go back and you think about what we said, because your health is the most important thing that you own. I mean, nothing in the world is more important than your health. I don't care if you're tall, thin, fat, short, you know, good looking or not. Your health is important. The only way that we improve it is that we know more about it. As a people, we need to be better healthcare consumers. And I would like to thank each and every one of our doctors for coming on and being part of this program. All righty. Just to go through the doctors, listen, Dr. Kevin Clark, and they're modest too. They don't tell you what they do. Dr. Kevin Clark is Director of Surgical Oncology. Dr. Kendall Sprott, he's a MD, JD. You mean that he's legal, he's a lawyer as well as a doctor, you know, and he's a CEO of Matheny Healthcare. Dr. Nelson Aluya, I mean, he is, I should say, I'm going to call him Mr. Nigeria because he's looking at us, I know, because he's on it. I mean, Dr. Court, you, what you do in your medical missions going to Guyana is just incredible. As far as Dr. Patrick Anderson, he's our goodness gracious. He's the brains of the outfit. He's the director of GYN Surgical Oncology. And then we have Dr. Lee. I'm going to give them their props here. Dr. Lee is the orthopedist. I mean, you know, hey, every joint in the world can be solved by Dr. Lee. And Dr. Dwayne Fredericks, thank you for coming on. Bariatric surgery. Listen, with all of our people that, you know, that look at African-American females, the studies have shown that 70%, close to 70% of African-American females are considered overweight. 50% are considered more obese or morbidly obese. It's in your realm. This brother, he has it. So I just wanted to give the brothers their prop. Thank you very much for being part of the panel. Listen, we're going to do this next month, second Saturday, 1 o'clock. Let me just end up here. Number one, I want to thank OBHealthy for allowing us to use their platform. You know, go to their website. It's a weight loss website as well as nutrition and health. And they do it, and they do it from an African-American flair. Second, do not change any aspect. I mean that. Do not change any aspect of your medical care until you consult your physician. It's all about caring and sharing. In our neighborhood, guess what? It all happens by word of mouth. We want you to go out and tell everyone that we exist, that we're here trying to answer every question, trying to increase the health knowledge of African Americans so that we can not only live longer, but live long and be healthy as we do it. All righty? So I'm just telling you, as far as I'm concerned, I'm just so happy that we're able to bring this to you. The brothers, the doctors that are here, we're all in it to the end. We really want you to increase your medical knowledge so that you can take better care of you and your families. So until the next time, we have our webinar, which will be the second Saturday of each month at 1 o'clock. I would just like to say, take care out there, guys. Wear your facial covering. It's important. This virus is not kidding. We have seen so many of our friends, our good friends, and even physicians we've lost. Wear your facial coverings. Isolate yourself if you think you may have it so you don't give it to someone else. I mean, keep your social distancing. Don't care what anybody says. Until we get a vaccine or appropriate treatment for this, we have to be diligent in protecting ourselves and protecting our family and others. Until next time, I'm going to sign off, and I'm just going to say peace until the next time we see each other. Right. Next month, I trust that we're here, and all your family members, all your sorority and your fraternity members, everybody join in. All right, peace, everyone.
Peace out.
Peace.
All right. That was good.